In this lecture, I will cover viral infections, helminths, and arthropods. So starting out with Verruca vulgaris, obviously verruca can occur in all ages on the hands, fingers, knees, etc. These are firm keratotic papules. We can see them more often in chronically immunosuppressed patients, especially post-transplant patients, who often have numerous warts, as you can see in this picture, all on the dorsal hand, wrapping around to the ventral aspects, often involving subungual spaces as well. The etiology will include HPV subtypes. There are various subtypes that can lead to Verruca vulgaris. So histologically, we can see and diagnose verruca. However, understanding exactly which HPV subtype led to the verruca is difficult unless we do some additional testing, maybe some in situ hybridization, especially if we're worried about low risk versus high risk subtypes. Here is a classic low power image of Verruca vulgaris. You can see this inward buttressing of the edges. It kind of wraps around and encompasses the lesion in its entirety. Then you have these undulating papillomatous upper and lower ups and downs of the epidermis. And if you notice at the tips, right where you have that transition from granular layer to the keratotic layer, the stratum corneum, you have a concentration of cells that have a clearing of the cytoplasm and some punctate basophilic granules per se. And then you have these towers of parakeratosis and some areas of intracorneal hemorrhage as well. So this is a classic verruca. However, oftentimes we get squamous cell carcinomas that have HPV influence, or we have hypertrophic actinic keratosis that have HPV influence, seborrheic keratoses, which have HPV influence. Because HPV can infect any part of the skin, especially other types of squamous lesions, we often do see components or architecture and cytology suggestive of HPV effect within multiple types of squamous lesions. So keep that in mind, because in real life, you often will see overlap. This is another classic picture of the coilocytic changes and those punctate basophilic granules with overlying parakeratosis. You see right underneath that papillomatosis of the epidermis, you have elongated dermal papilla, dilated vessels. So again, this is a Verruca vulgaris. This picture is a good illustration to show you that some of the coilocytes really have a prominent halo and an enlarged basophilic punctate staining, but it looks different than some of the other coilocytes that you see. And sometimes this resembles just an artifact that you can see around keratinocytes in general. For example, if you go down lower, you see some kind of halo artifact around keratinocytes. So it may not actually be coilocytic just because you see a halo. So you really have to take it into context of the entire lesion. You wouldn't want to diagnose Verruca vulgaris just because you saw one or two of these, but looking at the entirety of the lesion, then you could start to believe those are true coilocytes. Just looking at the elongated dermal papilla and the dilated vessels that you often see in Verruca. Now, if I see something that looks like a Verruca from low power, I still go to high power and really interrogate the keratinocytes to make sure that there's no high mitotic figures, no significant nuclear pleomorphism or cellular atypia, because again, as I said, you can have warts gone bad, as I like to call it. So HPV leading to squamous cell carcinoma, and you just don't want to miss a skin cancer because it looks like a verruca on low power. So interrogate these lesions when you see them. Plantar warts are very stubborn lesions, usually caused by the HPV subtype 1, HPV1. On histopathology, we'll show you the example of the prominent eosinophilic keratohyalin granules that you'll see. And we say keratohyalin granules. In reality, what we're often seeing is a mixture of viral protein as well as the normal proteins within the maturing epidermis. There's a lot of architectural deformity, and with the viral particles causing just kind of a disarray of the normal architecture. So you'll see punctate eosinophilic staining, which can represent normal proteins that have aggregated or even viral proteins, along with prominent basophilic areas, which represent keratinocyte nuclei, but also the DNA staining with hematoxylin from the wart itself. So thinking about that and looking at what Myrmecia wart looks like, which is a deep, complex endophytic growth, you'll see these prominent eosinophilic cytoplasmic inclusions. And this is a great example. So it actually, they do look a lot like Henderson-Patterson bodies in isolation, but you'll see when we cover molluscum, it looks different. So if you were to confuse this with any other diagnosis, it would be molluscum because of these large eosinophilic inclusions. Hopefully you'll be able to appreciate the differences, and molluscum obviously is much smaller and more isolated and compact than a Myrmecia wart. So you got to look at the entire size of the lesion too, if you were given a digital slide, to try to just figure that out. So here you see the kind of wide array of purple transitioning to pink. You see all those, the spectrum of representation of shades of pink and shades of purple here, because there are varying amounts of hematoxylinophilic and eosinophilic inclusions that the virus produces, along with destruction of the keratinocytes. Verruca plana is common in children. They often show up as flat, smooth papules. Usually they're only a few millimeter in size. So if you hadn't seen this before, you weren't suspicious of viral warts, you may think this is some type of follicular occlusion or small perioral dermatitis or acne type eruption. So now you know. They can coalesce. They're often numerous on the face, hands, and shin. Multiple plain warts are often seen in HIV patients due to the immunosuppression. Now, this type of wart, you more frequently see those halo-like coilocytic cells. So I hope that you can appreciate, compared to the previous examples of Verruca vulgaris, where you saw a lot more dense basophilic staining collections in multiple groups within one cell. Here you mainly see kind of a punctate basophilic area and then the surrounding halo around the single cells. So that will you more often see in Verruca vulgaris, in Verruca plana rather. So you can also see that it's pretty flat here, so not as papillomatous, it's not as acanthotic. You're not going to have the ability to see buttressing as well because these are so small and flat. You may not see any kind of intracorneal hemorrhage as well, given the size, given the fact that these are really often kind of not disturbed clinically and histopathologically. So this is a classic Verruca plana and could show up on your basic or core exams. Condyloma acuminatum. These usually present in areas that reflect some sexually transmitted disease. So commonly around the anogenital region. They show up as filiform papules coalescing into plaques, sometimes just large plaques. They're considered HPV mediated, but different types of HPV can lead to condyloma. Clinically, it's important to try to figure out, is this low risk or high risk? And if you see the request low risk versus high risk, we'll often send out for or send to the lab for in situ hybridization. So looking for HPV 6 and 11 for low risk and 16 and 18 for high risk. For example, there are many different types of HPV that can be associated with low risk and high risk, and we will cover some of that as well in the lecture. As I mentioned, 6 and 11 are often associated with low risk Condyloma acuminata. However, in high risk, high grade squamous intraepidermal or intralesional atypia or squamous cell carcinoma in situ, you'll start to see the HPV 16 and 18 and other high risk subtypes. So here's an example of Condyloma acuminatum. You can see that this would not be called squamous cell carcinoma in situ because the cells are not extremely atypical. You have relatively good maturation where you see a retention of the granular layer throughout. You have some papillomatous architecture and some dilated vessels in the dermal papilla, maybe some elongation as well. but the amount of keratosis or the hyperkeratosis above each kind of undulating epidermal ridge is not as much as you would see in a Verruca vulgaris. So this explains why they're kind of almost like a soft, fleshy skin tag-like appearance in many patients. And so Condyloma acuminata can be even more hyperplastic than this. It can be thicker. It can start to look a lot more like a verruca. So this is a really small one, clinically as well as pathologically. So if you go here on the granular layer, you'll see some coilocytic changes as well. Making the diagnosis of Condyloma acuminatum in somebody who is not expecting to be given that diagnosis can be a little bit controversial. And sometimes patients or clinicians may be a little upset about getting the diagnosis given to them out of the blue. So it's always good to kind of be descriptive here and say that you cannot rule out a Condyloma acuminatum if that's not what was clinically expected. Because at the end of the day, if it's in the anogenital region and it's showing these features, then you truly have to include that it's probably an HPV related lesion. And this just is a higher power view showing you those punctate basophilic granules that are so typical of viral cytopathic change caused by HPV. So even though you don't have a tower of parakeratosis, you have just a little bit of parakeratosis here, but you have such nice coilocytic change that you can really believe these viral inclusions are there. So this is a nice image representing that from McKee's pathology. Condyloma acuminatum, another just picture from Expert Path here, showing you these large halos around single punctate basophilic staining areas here. So this looks different than this. And that's what I want you to realize, is that you can see both this type of change and this type of change when you're talking about coilocytic change. Also, you'll notice the dermal papilla here is containing dilated vessels here and here, and it's probably elongated, although it's cut a little bit tangentially out of the plane of section. Now, HPV-related lesions can just cause proliferation with preserved maturation and not be considered malignant. And then, unfortunately, they can be associated with much more bad behaving keratinocytes that are proliferating at a higher rate, that are taking on very pleomorphic nuclear appearance and developing high and atypical mitotic figures in the epidermis, losing that maturation ability. So the granular layer is kind of starting to disappear because the division rate is so fast that they're not forming the normal maturation architecture of the epithelium. And you see these clear halos, some areas of punctate basophilic staining, and areas of full thickness atypia. So this represents high grade squamous intraepithelial lesion or neoplasia, or squamous cell carcinoma in situ arising within a condyloma, if that makes sense. So earlier when I was referring to Condyloma acuminatum, this is what I was referring to, that you can have some high risk HPV subtypes leading to this change. If someone says high grade squamous intraepithelial lesion or neoplasia, then that essentially encompasses boenoid papulosis. Boenoid papulosis often will present these brown pedunculated papules within the anogenital region, and they can occur in any place that you have HPV infection. When we say boenoid papulosis, that term has actually fallen out of favor now, because it's much simpler to just kind of say high grade squamous intraepidermal neoplasia, whether it be on the penis or the vulva. You may say penile, high grade penile intraepidermal neoplasia, or vulvar intraepidermal neoplasia, really just kind of expressing concern to the clinician that this is more high grade, that this should be considered a squamous cell carcinoma in situ. If you were to do an immunohistochemical stain to highlight full thickness diffuse expression of a protein to support full thickness lesional atypia within the vulvar region or the penile region, you would select a P16 stain, which often will, it's like a surrogate marker basically for the effect that high risk or high grade HPV virus infection has on the keratinocyte protein expression. So high P16 levels, full thickness P16 will often be a red flag worrisome sign. So bonoid papulosis, as I mentioned, again, it's essentially the same as high-grade squamous intraepidermal lesion or neoplasia or squamous cell carcinoma in situ. Bonoid papulosis is a term basically encompassed by that because it has clinically these papules and histologically bonoid or Bowen's disease histology. So often associated with HPV 16 and 18. You'll see discrete sessile papules in the genital region in young adults often, but could occur in any age. And as I said, histologically the same as HSIL or SCCIS. So here you see areas of what look to be full thickness enlarged cells, very pleomorphic nuclei, scattered levels of coilocytes. This example, you can see preserved granular layer. And so be a little bit careful about relying 100% on the granular layer presence to give you the diagnosis of bonoid papulosis or SCCIS or HSIL. The reality is that this is on a spectrum. And so you may have something that looks less bad as another example that you've seen. So if there's any, I guess, if you have any doubts on whether or not this is a more fully developed HSIL, then I would just advise to express the concern in the report that there are some areas of full thickness atypia and that you cannot rule out squamous cell carcinoma in situ. Epidermal dysplasia verruciformis, or EDV, is caused by defective cell-mediated immunity. It is often acquired in patients that are immunosuppressed or can even be associated with genetic mutations in the EVER1 and EVER2 genes. You'll see widespread flat warts, and you may, to the untrained eye, be surprised that these are warts, but these are indeed HPV-related lesions. Typically associated with HPV 5 and 8, that's where your test question will likely come from. Unfortunately, they have an increased risk of squamous cell carcinoma in situ. We mentioned that autosomal recessive mutation in EVER1 and EVER2 genes. Good test question there as well. So on histopathology, the kind of buzzword phrase that you should know about is a sea blue or a kind of a steel blue color change to some of the keratinocytes that have the HPV 5 and 8 infection. You can also see the speckled varying sizes of those basophilic granules. As I mentioned, we would talk about some of the HPV subtypes. So thinking about types of warts, the common warts are often associated with HPV 1, 2, and 4. Flat warts of Verruca plana are associated with HPV 3 and 10. Plantar warts are associated with HPV 1 or Myrmecia, and HPV 2 and 4 in mosaic Verruca. Epidermodysplasia verruciformis is associated with 5, 8, and many others. Buschke-Lowenstein tumor is associated with 6 and 11. Butcher's is associated with 7 and others. Laryngeal papillomas are associated with 6 and 11, as with the Buschke-Lowenstein tumor. And again, those are kind of considered low risk, quote unquote. We start getting into the genital dysplasia subtypes. Those are the higher numbers on average. So usually 16, 18, 31, 33, 35. Again, these are subtypes and these are numbers, but obviously there's different genetic codes for each one of these HPV subtypes, allowing for in situ hybridization techniques to identify which HPV subtypes are present in tissue. So when we talk about genital dysplasia, we're talking about bonoid papulosis, cervical dysplasia, cervical carcinoma. We talked about penile SCCIS, vulvar SCCIS or HSIL. We talked about VIN, which is the vulvar, or the PIN, which is the penile, high-grade squamous intraepithelial neoplasia or lesion. That's just more of the general term that can be present anywhere. Hex focal oral hyperplasia, Hex disease, is associated with HPV 13 and 32. That's always a good test question. And subungual squamous cell carcinoma is most often associated with HPV subtype 16. So what are the herpes virus subtypes? As you know from review, it's HSV, VZV, histologically indistinguishable. You can do some immunohistochemical stains actually for herpes simplex 1 or 2 and show that there is HSV at least 1 or 2, depending on what stain you're using. If you try to stain zoster with that, it may be negative. So you have to have a specific stain for the varicella zoster virus. Here's the example of the blistering eruption around the mouth in HSV1, for example. HSV2 is more often affecting the genital region. Varicella or chickenpox, as many patients who grew up in the 80s and 90s will remember getting chickenpox, especially before the vaccine came out. And herpes zoster often erupts in a dermatomal distribution clinically. So on histopathology, you see an intraepidermal destructive process forming a vesicle or a small bulla. On high power, you see nuclear molding, margination, and multinucleation of cells. This is the so-called 3 M's of herpes change that you can see on cytopathology. I have had some cases before where there was an ulceration with abundant neutrophils, and these cells were just kind of sneakily hiding within the neutrophilic inflammation. So if there's any doubt on whether or not there's herpes infection and it's extremely neutrophilic rich and not that classic herpes blister that you see, then doing some of those immunostains that we talked about to highlight maybe some of those hiding viral inclusions within the infiltrate is useful. Cytomegalovirus, often found in ulcers. Cytopathic changes often occur in the endothelial cells, and you can see intranuclear inclusions with clear surrounding halo. Changes of LCV often seen accompanying viral changes. Owl's eye inclusions is the buzzword that you should know about. So from low power, you might be thinking leukocytoclastic vasculitis or other some type of vasculitis. You may think that you're seeing some necrosis or some homogeneous eosinophilic change within those areas that are inflamed. And that's why changes of LCV are often seen accompanying the viral changes in CMV. On higher power, if you're lucky, you'll see some owl's eye appearance as located by this arrow here with this prominent nucleoli. Very easy to see nuclear outline, and then this kind of amphiphilic to basophilic rim around the outer part of the enlarged cell. And then luckily we have the ability to stain, so we can stain for CMV and see that there's a positive signal within the nucleus of these owl's eye type cells. Moving on to orthopox virus diseases. In general, these are DNA viruses. Examples include variola or smallpox, vaccinia used for smallpox vaccine, monkeypox. This is uncommon as zoonotic disease in Central and Western Africa, and unfortunately has recently reemerged in the US. And we've had cases and seen these cases that present clinically as ulcerations and vegetative plaques and ulcers that look similar to deep fungal infections like blastomycosis. And on biopsy, didn't grow anything. On stains, could not identify any fungal infections. And it wasn't until we tested for the monkeypox nucleic acid that we were able to prove that it was monkeypox, and the patient responded to monkeypox therapy. Cowpox, also zoonotic disease, usually self-limited. Here's an example of variola or smallpox, potential agent in bioterrorism, transmission by inhalation, incubation periods usually 12 days. There's different phases here. So prodrome phase includes fever, headache, and vomiting. About 3 to 4 days later, you get a transient erythematous and petechial rash followed by eruptive lesions on the face and limbs, leading to papules, which turn into vesicles, pustules, and begin to crust over. They heal with a pitted scar, which shows you the depth of destruction within the skin. The reservoir for cowpox is wild animals like hedgehogs and badgers. Infects cattle usually. Self-limited infection. Incubation period is 5 to 7 days on average. Also starts out as papules leading to pustules. May have eschars or necrotic ulcers, and the healing and recovery usually occurs in 3 to 4 weeks. So here you can see what are so-called guarneri bodies, which are the site of viral replication by variola, and similar inclusions in other infections as well. Molluscum contagiosum is caused by pox virus. We see this all the time in clinic on kids, on the face, trunk, extremities, pretty much anywhere. It's passed along by skin-to-skin contact, and in nearly all cases, is just a normal part of being a kid where their immune system is trying to figure out how to fight off these pox virus particles. In adults, especially around the genital region, it may be indicative of a sexually transmitted disease. So if you see this in adults only in the genital region, then that's probably a link with sexual transmission. Clinically, you see dome-shaped papules with central umbilication. And giant lesions, which we call giant molluscoid lesions, seen in which population? That's HIV patients. No surprise, if they're immunosuppressed and have a low CD4 count, they're going to be less able to fight off these common viral particles that are pretty much everywhere in the environment. So Molluscum contagiosum, from low power, you see these kind of collections of eosinophilic islands surrounded by the more purple keratinocyte epidermal islands. And on higher power, you'll see the mostly eosinophilic, very clean and well circumscribed collections of Henderson-Patterson bodies. Remember back when we were looking at Myrmecia, you also saw enlarged eosinophilic, very well circumscribed inclusions, but this is a much smaller lesion. You can tell it's not on an acral surface. Myrmecia you would see on an acral surface, it would be much bigger. And you would also see a variation of more purple and pink inclusions as opposed to just kind of this mostly pink inclusion population. This particular purple inclusion, you would see more of those in Myrmecia as well. So the percentages would be more equal to the eosinophilic inclusions that you see in Molluscum contagiosum. At the end of the day, using the size as well as the location is going to help you get Molluscum versus Myrmecia. So you've probably heard of ORF, Milker's nodules, another name of that. I mean, it's related because it's in the parapoxvirus family. So Milker's nodule is known as paravaccinia, and ORF is known as ecthymic contagiosum, but they're caused by parapoxviruses, but they have similar histologic appearance. So starting out with the Milker's nodule affects the udders of cows. On humans, you get papulonodular lesions that resolve with scarring. They are acquired via inoculation. ORF, or ecthymic contagiosum, made sure that I said contagiosum there as well. So ecthymic contagiosum, it's acquired by inoculation as well as Milker's nodule. You see small red to blue papules with flat top blisters. Later, you'll get crusting. So there's different phases, and depending on what phase you biopsy it, you may see different stages of destruction and healing. Complications include fever and lymphadenopathy. So in contrast to a lot of the other viral processes that you've seen, this is very destructive. So you can see just the amount of necrosis and kind of smudgy, diffuse, sheet-like eosinophilic staining that you're getting. Lots of areas of edema and just areas void of any tissue whatsoever. It's on an acral surface, so you can kind of imagine the clinical size of this would also correlate very well here. On higher power, you see just destruction, pure destruction of the keratinocytes, lots of areas of necrosis, just really amorphous outlines of what the keratinocytes used to be. And then what would probably make this a little bit more specific are these eosinophilic inclusions that you can see when you find some areas that are not completely blown out and destructed. You can find these eosinophilic inclusions that are very characteristic of ORF. ORF is highly likely to show up on your exams somewhere. Gianotti-Crosti syndrome. This is a clinical diagnosis often made in kids age 2 to 6. You see erythematous papular rashes on the face and limbs, plus or minus lymphadenopathy, and maybe even some acute hepatitis. In the US, this can follow many viral infections. So that's why that Gianotti-Crosti is mentioned in this lecture, because it follows viral infection in so many cases. In Italy, it often follows hepatitis B virus infection. In the United States, it can follow EBV infection, CMV infection, any kind of viral infection kind of triggers the immune system to react, and you get this reaction pattern of erythematous papules on the face and limbs. Usually it spares the trunk. So on biopsy, now if you had this biopsy and you had no idea what the clinical was, then it would be difficult to get the diagnosis. But what you see are areas of crust, some serum containing in that crust, some papillary dermal edema, epidermal spongiosis, a lymphoid infiltrate. Again, this is not going to be something that you're going to diagnose just by looking at the slide, but with clinical correlation, especially if the clinician said rule out Gianotti-Crosti versus Langerhans cell histiocytosis versus something else, then you could just say, well, it's consistent with Gianotti-Crosti given this inflammatory pattern. Again, clinical history of a recent viral infection, the clinical distribution of the papules on the limbs and the face, sparing the trunk, coupled with this, you'd be able to say Gianotti-Crosti. Hand, foot, and mouth syndrome. This is the result of Coxsackie A16 virus. Often see it in young children in the summer or the autumn. Unfortunately, they get oral blisters and vesicles and papules on the digits, the palm, soles, mouth, and buttocks, hence the name hand, foot, and mouth syndrome. It is self-limiting, but it can be very painful and it's highly contagious. What do you see on pathology? It looks similar to ORF in a way. You've got some really kind of blown out epidermis with necrosis, just diffuse edema, complete lack of normal structure of the keratinocytes. And usually you will not see inclusions as you would see in ORF. You wouldn't see it in hand, foot, and mouth disease typically. So again, hopefully they wouldn't put both hand, foot, and mouth disease and ORF in the same answer choices, because from low power, they can look similar. But usually in ORF, you're going to find those inclusions a lot easier on high power than you would with hand, foot, and mouth. Moving on out of the virus world and moving into flukes, tapeworms, and roundworms. We'll start with Schistosomiasis. So this is a trematode fluke. Involves freshwater snails. Basically, these cysts with organisms can get into the human skin. They can mature to adult females and males. They have paired adults that lay eggs in the human body. And the common types that you probably heard about when you were studying for step 1 are Schistosomiasis mansoni, S. japonicum, and that affects the liver and the GI tract. And then you have S. hematobium, which often will be involved with the urinary tract reservoir in the bladder. You can see the organism here, these kind of worm-like organisms. Now, they can exist in ova. So you can see an elongated kind of trematode fluke. What you'll see with the ova are actually 3 different morphologies. So the no spine ova, or the japonicum, you can just see the ova here with no visible or tiny apical spine and a thick wall. In hematobium, you see a thin wall and a thin apical spine. And then in mansoni, you see a lateral spine with a thick wall. So I would be kind of surprised if they put this on your exam, but you may, these pictures particularly, but you may see them in the tissue. And so here is an example of the kind of an apical spine appearance here that you would expect to see with the hematobium. This usually occurs around the anus and genitalia The ova leads to a granulomatous response, but hopefully you can see the ova in the digital slide or the slide that they show you on the exam, and then surrounding granulomatous response. And you may see group solid papules or warty vegetative papules and plaques as well. So here is that vertical spine of S. hematobium, as I mentioned, that you can see here. Depending on the plane of section, it may be difficult to determine Schistosoma mansoni or Schistosoma hematobium. So if they put this on the exam, they would probably expect you to just say Schistosomiasis. So Sparganum proliferum is a larval form of the tapeworm Spirometra, occurs in the tropics, forms a subcutaneous nodule, and the culprit is a white thread-like worm, a few centimeters to even up to 50 centimeters. So here is a cross-section of that worm. You may also see these are so-called calcareous bodies, kind of looks like calcification areas within the tissue. Elephantiasis, you may picture some areas or some clinical images of extreme lymphedema. And that's what you should remember about this. Elephantiasis can lead to associated inflammatory response, which leads to extreme lymphedema. The culprit is this Wuchereria bancrofti and Brugia malayi. You can see on peripheral smears, actually, of the Brugia malayi and the Wuchereria bancrofti. Onchocerciasis, also known as river blindness, can occur in tropical Africa. Can lead to chronic infection of the skin and the eyes. The culprit is the Onchocerca volvulus. The vector is the black fly. Clinically, you see papulovesicles, plaques, nodules, maculopapular rash. When we say maculopapular rash, what we're referring to are macules and papules within the eruption. This can lead to conjunctivitis, photophobia, and blindness. Here you see microfiliaria in the dermis. If you got lucky and caught this all in one plane of section, you'd be able to see the microfiliaria, which is nice. You may also be shown examples of adult worms in tissue. So you see these are larger cross sections of a worm, and on higher power, you can see the developing microfiliaria within the larger worm. Dirofilariasis is an infection that can occur in the Mediterranean region and in Florida, usually. D. tenuis, D. ursi, D. subdermata in North America. You may hear about the dog roundworm or D. immitis, where you can get pulmonary lesions from this infection. Usually, these are single subcutaneous nodules transmitted by mosquitoes. So when you see mosquitoes, they're not always relatively harmless. They can actually transmit extremely damaging infections, unfortunately. So how does this work? They transmit the microfiliaria to humans via the bite. Definite hosts are dogs, cats, raccoons, and bears. Here you see the Dirofilariasis on cross-section within the tissue. Kind of has this outer thick eosinophilic body with a lighter staining, thinner filaments of eosinophilic staining within the center part. Moving on to arthropods. So scabies, we all know scabies, Sarcoptes scabi mite. Affects the interdigital areas, the flexures and the ankles. Lesionally, you'll have papulovesicular lesions, nodules. You might even get crusted or keratotic, very thick hyperkeratotic scaly areas, and that's crusted or Norwegian scabies. If you're lucky on histopathology, you'll catch the scabies organism here. So you can see a cross-section throughout the organism with this very thick eosinophilic exoskeleton and other parts of the limbs and the legs have been sliced here, and they're out of the plane of section where you see connection. But you also may find some curlicues, as we call them, which are little remnants of eggs that the mite has laid. And I'll show you in a picture of that when we look at the Norwegian scabies. So if they said rule out scabies and you got a section where you didn't have the organism and you just saw spongiosis, maybe some lymphocyte exocytosis, maybe some eosinophils within the dermis, lymphohistiocytic infiltrate, relatively dense, it's a good idea to go ahead and cut multiple deepers just to see if you can catch the organism, because you may be missing it in the first section. So if the clinician is asking you to rule out scabies, then as the pathologist, you're going to have to do some deepers. Make sure that you're not missing it. So here is an example of the Norwegian or crusted scabies. You can see this diffuse hyperkeratosis or eosinophilic material, but then throughout you see these curlicues, as we call them, and these are little remnants of the scabies mite eggs that were left within that tissue. Insects or tick bites, these can be mosquitoes, flies, lice, for example. In tick bites, you often see that the tick can still be attached. We had a case that we biopsied the tick out of the patient. We saw the tick was there, and the patient didn't realize they had that tick for so long. And so we asked them if we could just go ahead and biopsy the tick out instead of try to pull it and risk retaining the mouth parts. And we went ahead and biopsied that. And there's a nice little YouTube video showing that tick that we captured within the section. So go back and find the tick video. It's pretty entertaining. So usually you can see excoriated papules, bulla nodules, and ulcers, depending on how robust that inflammatory reaction is. So this is an example of just arthropod assault or an insect bite. So you see diffuse lymphohistiocytic inflammation with scattered eosinophils. Here's an example of a tick bite. So you see the retained tick parts here in section. You may only get fragments of these little kind of yellow, thick areas of the tick. So be able to recognize various fragmented tick parts as well, and then the surrounding granulomatous or lymphohistiocytic inflammation around the tick. A spider bite, for example, brown recluse spider, results in necrotic eschars with pale and erythematous patches, depending on the evolution. You can see multiple colors within here, and that's just kind of reflecting the extravasated red blood cells, areas of hypoperfusion, areas of vascular coagulation, bruising that are in relatively mature stages that are resorbing or recently extravasated red blood cells. So that's what's resulting in all these variations of color, as well as tissue necrosis leading to the black color that you see. You can even get diffuse intravascular coagulation or disseminated intravascular coagulation as a result of spider bite, as well as hemolytic anemia in serious cases. So here is a biopsy showing the effects of a spider bite here from low power, just to appreciate the superficial, mid, and deep inflammation and widespread destruction of the epidermis and necrosis as well. Some areas of intravascular coagulation, microthrombi. So we're moving into some other organisms that you should be able to recognize, at least on the slides, just because they're high yield to ask about. So myiasis is an infection of fly larvae or maggot in tissue caused by Dermatobia hominis, often in tropical areas. And the key finding here is a thick corrugated chitinous wall with pigmented septae, striated muscle, and gut can be seen within these organisms. So here is that undulating thick chitinous wall with the pigmented septae and the striated muscle that you can see, as well as the gut. So try to find many examples of myiasis. So if you get that slide on the exam, you can make the diagnosis. Tongueiasis is caused by Tunga penetrans, or the sand flea. It's a gravid female flea that burrows into the skin. It affects the feet in most cases. So you'll see these on acral skin. Presents as pruritic, painful papulonodules, and often occurs in Central and South America, the Caribbean, and Africa. The reservoirs are dogs, cats, and rats. So here is tongiasis. You see it's on acral skin. It's a very large flea, and you see these kind of internal structures of the actual flea itself. So you can see it burrowed into the skin. So this is a great example from low power to see on acral skin. It's just kind of embedded right here into the skin. You can see these, again, on acral skin, these spines that are projecting, again, a thick chitinous wall, some striated muscle, a blood-filled gut, and some tubules. So it may sound a lot like myiasis here with the descriptors, but you usually will not see the acral skin on the myiasis, and they may just show you the organism here. And with tongiasis, it's larger and it's kind of embedded down into acral skin. So those are going to be helpful hints for you, because you'll still have some chitinous wall, some spines, blood-filled gut, and tubules. You may not see as much. So here you can see that striated muscle that's right next to the chitinous wall in myiasis and tongiasis. You can also see the striated muscle as well next to the chitinous wall. So again, take it into context. I would say most likely if you're tested on tongiasis, it's going to be on acral skin. And here you see numerous eggs within the tongiasis within the sand flea. So this is just another example of smaller organisms within the larger organism. So numerous eggs in tongiasis. And that is it for the lecture material for this topic.